Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, June 16, 2025, we are speaking to Dr. Carlos del Rio, Chair of the Department of Medicine and Distinguished Professor of Infectious Diseases at Emory University School of Medicine. Dr. Del Rio has held numerous positions at Emory University, including co-director of the Emory Center for AIDS Research, or CFAR, and co-PI of the Emory-CDC HIV Clinical Trials Unit and the Emory Vaccine and Treatment Evaluation Unit. A native of Mexico, Dr. Del Rio was also the executive director of the National AIDS Council of Mexico in the 1990s. His research focuses on the early diagnosis of HIV, access to care, engagement in care, and compliance with antiretroviral therapy and the prevention of HIV. He has worked for over a decade with hard-to-reach populations, including substance users, to improve outcomes of those infected with HIV and to prevent infection with those at risk. He is a member of the National Academy of Medicine and a board member of the International Antiviral Society USA. Today, Dr. Del Rio joins us to discuss the topic of providing care to foreign-born and hard-to-reach populations. Carlos, welcome to the podcast.
Happy to be with you, Mike.
So let's start by just defining who are the hard to reach. I guess the simple answer is, well, by definition, they're hard to reach. But how would you put a label on that?
Well, Mike, I don't necessarily like the term hard to reach populations because I really think that the problem is they are hardly reached populations. These are populations that we don't make the efforts to reach, right? So they're hardly reached. They're not hard to reach. If you do the right things, you can reach them. You know where to find them. They come to the ERs, they come to places. So they just need to be reached in different ways. But I think that's the issue. The issue is that our typical approaches are not necessarily what they need. So we need to think about what works best to the patient. And if the patient cannot come to us, we have to go to the patient. We have to find the individuals. We have to get the services to where the individuals are. So let's not use hard to reach populations. Let's talk about the hardly reached populations and what do we need to do to no longer make them hardly reached.
So give us some parameters about who fits into that rubric. Who are the people that are the folks who we need to put special effort into?
Well, there's all sorts of people, right? I mean, you could start with adolescents. You can start with men. You can start with working individuals. You can start with people who have other priorities. If your priority is to get food for your family and you cannot miss a day of work, or your priority is to find where to sleep, going to healthcare and spending the whole day waiting to be seen at a hospital and or at a clinic to be seen for 15 minutes is not necessarily your priority. I remember some years ago when we did a study in the HPTN in which we thought that the research focused on the premise that young MSMs, primarily African American and Latino MSMs, did not have difficulty reaching HIV testing sites, STD testing sites. So we needed to give them a health navigator to get them tested, get them into care. And what we found out is that they knew where to get tested. In fact, many of them had already been tested. But what they needed a navigator for is to help them clean their criminal record, help them find the job, help them find housing. So their priorities, which is also healthcare, housing is healthcare, employment is healthcare, their priorities were not necessarily our priorities, right? So we also need to think about those issues about people that are sometimes, hard to reach or hardly reach is because they have other priorities. They don't work in the same environment that you and I worked, and the environment, I would say, of privilege of having health insurance, having access to care whenever you feel like it. And that, to me, is at least one population. But then you can go down the road. You can talk about people who can't speak the language. If I couldn't speak the language, I can imagine myself being in Japan and being ill and trying to go to a hospital. I think it will be very hard, right?
Very hard.
And if I lived in a country I didn't speak the language, I think getting healthcare will be exceedingly hard. I think that people who have different cultural beliefs, that this is a totally different culture, have difficulties accessing care because simply care doesn't comply with them. The lack of health insurance, the fact that healthcare in our country depends on insurance, depends on employment, the financial way in which we're paying for healthcare is so convoluted and complex that most people don't understand it. People that have distrust in the health system. So there's a variety of different populations that simply are unable to access healthcare and the usual ways, and that we need to develop different mechanisms to get them into care.
So it sounds like a general rule of thumb is figuring out, for example, who's missed visits. That would be a nice signal that there may be an issue. And then identifying what that individual barrier is, and it could be any one of the myriad of things you listed, and then tailoring a response to sort of take those barriers down or take them away or to enable them to participate in clinic. Some clinics, like the San Francisco clinics in particular, and you may be doing this at Emory, but having mobile services actually go to where the patients live
I mean,
in the community.
mobile vans are useful, but I spend a fair amount of my time in research trying to understand, is there a way we can predict when somebody shows up in our clinic? Can you predict who is going to miss appointments? Because if you could, I mean, if you say, well, we're going to have additional services for everybody who is poor and uninsured. Well, in our clinic, at the HIV clinic that you know well, the Ponce de Leon Center, most people are poor and uninsured. You would have to give it to everybody. So being a minority, being poor, being uninsured doesn't necessarily help you limit the number of people who would need the services. But yet most people actually come to their appointments. So is there a way for us to predict who's not going to show, who's unlikely to miss appointments, so we can actually, again, don't wait until they miss the appointment, but be proactive about it. And in a study that we published some years ago, John Galasanti, I think, was the lead author. We looked at this, and what we found, which is fascinating, there are a lot of predictors that about youth and age and housing stability. But one that was really very, very, very important, Mike, was actually a great predictor, was having changed your phone number. Having changed your phone number was and it's interesting because we ask people, what's your phone number? But we never ask them, have you changed your number? Because if you've changed your number in the past year, that's actually a great predictor that you're unstable and you're likely going to miss appointments. So it's even how we start asking for patients. I had a research outreach a person that was fantastic. OC was just incredible. He would find anybody for any study. Our retention in studies were really, really good. But OC taught me a lesson very early on. He said, Doc, I don't need you I don't need your nurses and your staff to tell me the name of the patient and the phone number. That's not helpful to me when I try to find people. What I need to know is, where do they usually hang out, especially when they're in trouble? And number two, what's their nickname? Because if I know their nickname and I know where they hang out, I can find them. And sure enough, that was exactly what he needed. So, think about our intake forms. We got to ask people, have you changed your number? We have to ask people not only for your name, but what's your nickname? And we have to ask them where they usually hang out. Who do they go to when they got in trouble? We normally don't ask that in our clinic, intake forms. So think about things we need to modify in order to then do the interventions we need for people that are hardly reached.
Great advice. And now you've shared his advice with all of us. So I think that's fantastic. We should probably implement that next week in our clinic. Fabulous. You mentioned earlier about the foreign-born individuals. You especially mentioned language barriers, which I couldn't agree more is a big problem. I mean, some of our staff are multilingual, mostly Spanish and English, but you mentioned Japan, and it would be harrowing. I think everybody can relate to that. There are some unique challenges that foreign-born individuals have, especially in this country. You mentioned health insurance. Some of it nowadays is their immigration status, but let's divide this into pre-2025 and then after January of this year. So before ICE, if you will, really being aggressive, what were the things you were noticing that are still carrying forward today? And then we'll come back to immigration status of being a barrier.
Well, certainly language barriers is a very important one, right? communication difficulties due to language differences significantly hinder effective interactions between healthcare providers and patients. And of course, this leads to a lot of things. It leads to misunderstanding about a diagnosis, about a treatment, about follow-up instructions, and therefore it erodes trust and potentially impacts patient care. I mean, if I tell a patient, hey, we need you to get a CT scan, and please call this number to get a CT scan, and they don't speak the number, they're not going to get the CT scan. So those are the issues that we need to remember, that, if you don't speak the language, it's really, really hard to get the care that you need. There's also, of course, cultural differences, values, practices, beliefs in healthcare, differences in professional norms, differences in beliefs of what is illness, what is treatment, what is health. Of course, we talked about financial constraints, the lack of health insurance, the way that, you don't know how much to pay for healthcare in this country. I mean, I remember, one time that my mom, was having early signs of dementia, and she came here to Emory, and we had her evaluated. And even though, she lived in Mexico and she had insurance, as far as, her insurance in Mexico out of the country was by reimbursement, right? She would have to pay and then get reimbursed about what she had spent. And so I was getting her seen here in the U.S. And of course, as far as the U.S. was concerned, she was uninsured. So I had to go to financial counseling, get on the phone financial counseling. I didn't tell them I was a doctor. And, they said to me, well, your mom is going to need an MRI. And, the cost of the MRI, including their interpretation and everything, is, I think they said something like $4,000. They said, but if you pay today, cash, credit card, check, whatever you want, the cost will be $800. And then when you get the bill from the health system for the $4,000, just send it to us and we'll cancel it because you already paid for it. But I was able to do that negotiation. I felt like I was in a developing country in the market bartering, right? I mean, I was bartering for the service because I'm able to talk the language and negotiate. But if you don't speak the language, you would not necessarily be able to say, hey, I got cash, I need to pay for this. How much is the real price? How much would you take in cash for this to be effective? And that to me is also a huge issue, right? People, I remember when I was practicing in Mexico, people also didn't have any health insurance, but at least they knew how much things cost. You can say an x-ray costs X amount. They would shop in cash and pay in cash or in credit card or whatever. And, that's the way, that's the way. I remember one time years ago, I had one of my patients from Mexico come to see me here at Ponce. And as he was leaving, a very wealthy individual, as he was leaving the clinic, he needed his prescriptions for his antiretrovirals. And he went to the drugstore and wanted to pay with American Express. And the pharmacy at the clinic said, oh, they called me and said, Dr. Del Rio, we can probably get him financial assistance and get him made up. I said, take his money. This guy is wealthy. He's paying with American Express. But our clinic didn't know how to accept American Express, right? So, I think there's also that component that the way people in other countries, and it's not just the poor, pay for healthcare, it's very different than how we pay for healthcare in our country. And that's very disconcerting. And then, of course, you get a bill for thousands of dollars for things that you don't even understand. All of us have gotten bills from healthcare that you said, what? What's going on here? You charging me this for this? It doesn't make any sense, right? So I think the financial lack of transparency in finances in our country are very complicated for anyone, but they're particularly complicated for an immigrant. Now, if you talk about an undocumented immigrant, it gets even more complicated, right? Because even before this administration, we had heard, well, if you're undocumented and you use, government services, you when you apply for legal status, that may compromise your ability to get legal status. So people are very concerned about that, and therefore they will not necessarily want to get Medicaid or other services. And then there's of course for the undocumented population, there's many other issues like one of the first questions you ask all the time as you check in is, what's your social security number? Well, if you don't have one, then that's an automatic stop, right? Hey, I don't have that, so therefore you're automatically if they close the door, they say we can't take care of you. So there are a lot of issues. Now, once you get to 2025 and you start seeing really being an undocumented immigrant being really being considered almost a criminal, then you start getting into a very complicated issue. And I suspect that we're going to see some consequences of this. I suspect undocumented immigrants with HIV and with tuberculosis are likely not going to want to come to healthcare. And we're going to see transmission of diseases that we're not seeing right now because we can take care of people. So there are unintended consequences that impact everybody, right? Because if you're in the subway with somebody who's an undocumented immigrant who has TB, as you well know, M tuberculosis doesn't care if you are documented or undocumented, legal or illegal. You will too get TB from breathing the same air as this individual. So I think that's bad for public health. So at the end of the day, the way we are making it hard for undocumented immigrants to access healthcare is bad for the health of all Americans.
Yeah. So I think with this, I've already seen it as far as the post-2025 era. There are a lot of patients who will not show up to clinic, and that's not just TB and HIV. That's across the board. That's for cardiology, et cetera. The fear in the community of people who even have visas and are here, quote unquote, legally, they are afraid to show up because they're afraid of an unannounced ICE visit and a deportation. And a lot of the folks, as you know, are rounded up and then sent somewhere and they can't be found.
Yeah.
They're in a detention center in Louisiana or
No.
some other state, and family can't reach them. They don't have a phone. So they're scared to death of that. And I'm not sure exactly what we can do about that.
Well, I think to me, there's nothing worse that, it reminds me of Roosevelt, who said, the only thing we can fear is fear itself. I mean, the fact that you have to live in fear is a terrible place to be. And living in fear 24/7 is just devastating. And the fact that we in this world where life is already hard, but you want to pursue health, you want to pursue happiness, you want to pursue the best for your family, to have people who live in constant fear of somebody knocking at the door, somebody, finding them at a clinic, somebody pulling them out of a church, pulling them out of a school. It's devastating, and it's something that I think is not only inhumane, but it's really a very shameful way. I feel shame that we are where we are right now because the reality is that immigrants, documented and undocumented, have contributed a lot to our country, right? And I say that, recognizing that I am too an immigrant, but let's be real clear. The impact of immigrants on healthcare in the United States is pretty significant, right? The immigrants make about 13.6% roughly of the U.S. population, but they are 28% of the country's physicians and 37.9% of the home health aides. In fact, taking care of the elderly in our country, geriatric care in many parts of the U.S. is primarily done by immigrant workforce. So the reality is we depend on immigrants in a significant way in our healthcare workforce. And yes, some of them, most of them are legal, but many of them may be, undocumented. And the reality is that, we still depend on them. We need them to be, helping with taking care of elderly individuals. And when I read the other day that ICE was going into parks and taking care of, sort of detaining, people who were taking care of caretakers of elderlies who they were walking in the park. So maybe that caretaker is not going to take that older individual to the park and to outside because they're afraid of doing so. That is terrible. It just makes me upset, makes me mad, and makes me incredibly sad.
Well, you're not alone in your feeling. There's an awful lot of us who feel the same way. I think maybe there's a glimmer of hope right now in that last week the president said that he's got messages that those in the agriculture trade, those who are helping in areas of business, restaurants, etc., that they're finding construction, that they're finding that the removal by ICE of those individuals is crippling the business. That's maybe a functional reason, but it kind of shouldn't be needed in the sense of what you're saying about being humane and doing this in a way if somebody wants to be investigated for being here illegally, um, okay, fine. You don't have to just pull them off the street. There's calmer, less fearful ways to do that, like we had done in previous years.
And again, people who are the great majority of undocumented immigrants are not criminals. They're actually actively contributing to the economy, are paying taxes. Many of them are paying Social Security. They're actually contributing to our country in ways that that we also need to recognize, right? They are the people building our roads. They are the people building our houses. They're serving our meals. They are doing our yard work. I mean, come on, let's really stop this xenophobia and really think about how our country. I've always said that we as Americans can eat fairly cheap food because of the immigrant hand that picks up our lettuces and our strawberries and our grapes and other things in our crops. But so Americans like the immigrant hand. They just don't want the immigrant body. But the hand is something that they actually really appreciate because it gives us, food that at price. Imagine if you had to pay people real salaries to do that, or if all the immigrants disappear from the farms. I don't think there are Americans, legals that will go in there and do the same jobs. So you're absolutely right. The immigrant hand is very important, but let's just forget about just valuing the hand, and let's start valuing the whole individual.
Yeah. And so I think it's important as we move through this that folks understand there's kind of, I'm oversimplifying, two different types of immigrants working in the United States right now. There's the quote unquote legal immigrants who's registered, might even have a green card or visa. They're on the books, and when they work, have a Social Security number and pay taxes. The person who is not registered that way, the so-called illegal immigrant, is also working and doing things and also paying taxes in many cases. And those individuals are contributing not only by their hands, but also by paying into the tax system.
But also, they're not divided. It's not like you can say, well, this house is undocumented and this house is documented. Frequently, in the same household, you have a mixture, right? You have documented and undocumented individuals. Maybe the father is an undocumented immigrant, but the mother may be an American citizen, and the kids are Americans, and and the grandmother who came from Mexico or Guatemala or somewhere else, maybe she too is undocumented. But again, so this populations are all together. They don't go home and say, "Hey, I'm undocumented. I'm They all consider themselves Americans. They all are contributing to the U.S. well-being and to the U.S. economy and to the U.S. workforce and to the fact that we have a booming economy in great part because we have that young immigrant population that works really, really hard.
Yeah. And, I think when most people look back at their own family, and in your case, you're a first generation immigrant, but in my family, I'm a third generation. I think most people can point to the time where someone in their ancestry came to the United States through immigration.
Well, so it's interesting, Mike. You probably don't know this. Most people don't, but actually, my grandfather, who was from Mexico, studied medicine in Mexico, he was also involved in politics. And when he went after his medical school, he went to do his surgical training in Europe. When he came back to Mexico, he was in the wrong side, in the wrong party, so they wouldn't let him get off the boat in Mexico. So he went to the U.S., and he actually settled in San Antonio, and he practiced medicine in San Antonio for many, many years. And in fact, my father was born in San Antonio, Texas.
Oh, okay. So you're technically a third generation.
Well, my father was born in San Antonio, Texas. And then when the war started, my grandfather, I think, quite frankly, I've never discussed it with him because he died when I was very young. But my grandfather, I think, was fearful that his boys, he had 3 boys. My dad was the youngest, that his boys were going to go to war. So then the administration changed in Mexico, and the president now was a good friend of his. So he left San Antonio, went back to Mexico to work. And my father didn't start speaking Spanish until he was 12. And that was because before that, in San Antonio, you didn't say that you were Mexican. It was bad. So my grandfather's patients would introduce him as our Spanish doctor, not our Mexican doctor. And they didn't speak Spanish because, you didn't want people to know that you you were anything, anyway. I mean, blacks and Hispanic and Mexicans were not allowed in many places, right?
Mm.
So then my father, in Mexico, he then stayed, went to law school and eventually became Chief Justice of the Supreme Court of Mexico, having been born in San Antonio. But then I was born in Mexico, but interestingly enough, my son and my wife were both born in the U.S. So what I'm trying to say by that, my wife was born in Seattle when her father was doing his psychiatry residency, and my son was born here in Atlanta when I was doing my medicine and my wife was doing her pathology residency. So at the end of the day, here you have a family in which we have people born in both sides of the border, and we don't see necessarily ourselves as American or Mexicans. We see ourselves as being citizens of the world and being part of this ecosystem. So again, this is very common in many families. This is not something that just happened in my family.
That's a fantastic story. So our time, as predicted, has gone by very quickly. This is the question I've had to end with was maybe impossible to answer. It's what's the next couple of years going to be like? And I don't think we can answer that.
Well, but we can do certain things. I think in our clinics, we need to show passion and compassion. We need to show passion for healthcare, for health equity, for access, and we need to show compassion. We need to have, be receiving, be welcoming. I think about HIV clinics when people with HIV were being, ostracized, when they're being discriminated in many places. At our clinics, we offer them a place that they can come and feel safe. We offer them a hug. We offer them compassion. We offer them a shoulder to cry on. So I think we need to make a special effort that our immigrant populations feel welcome in our clinics. I think we need to have available language services, either through interpreters or through people who are multilingual, so they can actually receive care in the language of their choice. And I think we also need to be very open to providing the legal aid and the other services, or at least direct them to the places where they can get the legal aid, the immigration aid, and all the different things they're going to need during this very difficult times. Because the reality, as I said, is, you may have a patient in your clinic who is undocumented, but their wife is a U.S. citizen. So they need to know what can they do? What are the things available to them in order for them to feel safer? And Mike, I cannot end by saying, but if you are a U.S. citizen, please vote. Voting is very important, and voting in a democracy is how the will of the people is exerted. And to me, I've always been surprised about how the high rates of absenteeism in our country. I think when you're able to vote, you should always vote. And I encourage people to get educated into why is it important to vote. I encourage people to access their members of Congress. I encourage people to be more active politically and to do advocacy, because at the end of the day, our patients need us.
Great words to finish on. Thank you, Carlos, for an enlightening conversation, and let's keep plugging. You just got to keep pushing forward, but I think your words will help a lot of folks reorient to things that we can do on the ground to make life better for a lot of people.
Take care, Mike. Good talking to you.
Okay, thank you. Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed on this podcast do not necessarily reflect the opinions of the IAS-USA and its affiliates. And the viewpoints of the individuals on this podcast do not necessarily represent the viewpoints of their institutions. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode. Thanks for listening.